Alrighty. Hopefully y'all can hear me. I did go ahead and turn off the fan just in case that was causing a problem. But I think we're just about at 10 o'clock. So I will get started. I'm going to share out my PowerPoint for y'all. And if I can, just get a confirmation that you can see my screen. Yay! Good. Thank you. Oh, all right. Well, happy Wednesday, and welcome to our webinar on hypertension and cardiovascular diseases. What you need to know in today's MT-HDS world. And I will go ahead and take your questions. Okay, sorry, you don't see the PowerPoint. That's me. My bad. I knew it. Okay. Can you all see it now? Should be a big heart and a stethoscope. Great. Thank you all. But we will go ahead and get started. I do have a lot of information to cover as usual. So I do take your questions. If you want to just go ahead and put them in the chat box for me, I will take them as I can, or at the very end. And if you folks are not muted, please mute yourself. Okay. Alrighty. Please don't unmute yourself. Just type in the box. That would help. Okay. Anyway, we will go ahead and get going. The first thing we'll talk about is that this really isn't a webinar about the conditions. Okay. I really want to emphasize what I'm trying to kind of convey through this webinar. It's really about the words and phrases. I think the problem with us as MTs, we think that we have to be a doctor, and like the end of the show, that's the cop show, not a doctor. We're not a doctor. We can't know everything. It's not our job to know everything. Our job is to research to the best of our ability and make sense of these dictations that we're being kind of bombarded with. So I do want to say that right off. It's actually the business of what we do is putting together words and phrases intelligently and knowing what the intent is. And if the intent does not make sense, then we flag that for somebody else of a higher power or higher authority to go over for us and figure out. Okay, so the first part of our webinar is going to be about hypertension. There's a lot of different types, and you hear a lot of different terms and phrases when you're talking about hypertension. You can have primary hypertension, which is not related to any medical condition. You just got really unlucky and you got it. Or you can have secondary hypertension, which I personally happen to have. It can be related to something else. Your kidneys, your arteries, heart or endocrine systems are the most prevalent, okay? And it can also strangely be completely related to or caused by sleep apnea. So I do feel like this kind of information is really valuable for family and friends. I know from personal experience, if I was not an MT, I probably would not have been able to figure out that I had renal artery hypertension. My doctor couldn't even figure it out. So she gave it a blanket diagnosis as stress. So I do think, you know, knowing some of these basic things are good for our work life, but they're also good for our personal medical health and the health of other people close to us. So essential hypertension means that somebody, and this is a really important phrase, essential hypertension. It just means that it kind of exists on its own. You'll see or hear a lot of people misinterpreting that as central. It is not. It is essential hypertension. So keep that in your memory banks for words and phrases. But it usually means that you've had a BP elevated on 3 or more visits to a doctor's office. You may or may not have symptoms. Some people have extremely high blood pressure and have no symptoms. It can be related to extraneous factors like being overweight, smoking, drinking too much, a diet high in sodium, let's say, and also it can be based on family history. You can also get what I was saying, secondary hypertension caused by something else. So that's going to be your OSA, or you could have an adrenal tumor or disease. That's one of the things that they wanted to find out if I had right away, because my hypertension came out of nowhere. It can be something that's a hormone imbalance. It can be due to thyroid. The next one, renal artery stenosis, is exactly what mine was related to. And had I not known about that just from my typing, I probably would have had to go through a whole bunch of other tests, because I did bring that up as a differential diagnosis, and they decided to test for that and adrenal tumors without doing all the other things first. And bingo, the first one they did was the MRA, and I did have stenosis. So you also can get it from overindulgence in sodium or alcohol. You can also strangely get high blood pressure. It can affect your blood pressure taking too many nonsteroidal anti-inflammatory drugs. You can also get it from things like Afrin and Sudafed. So if the cause is found, as in my case, usually it can be treated, and it does not become a systemic problem for the rest of your life, let's say. So isolated systolic hypertension, you might hear that. That just means that what is happening, the top value, the systolic, it rises above 140. The diastolic, the lower number, bottom number, stays normal. Most people over 65 will have this just because their arteries are no longer as expandable. They lose their elasticity. So actually the systolic number becomes much more important in older people than the diastolic number, just because that kind of gives them an indication of how hard your heart is trying to pump blood through your arteries and veins, and that is kind of what can cause strokes and heart attacks. So that's one thing that they really watch. Another interesting term, malignant hypertension. What the heck does that mean? Well, malignant means something really bad. It's obvious that that's not what we want to happen. So malignant in this case just means really, really bad. It only occurs in about 1% of people that have hypertension, but it can occur in young adults, African American men especially, and pregnant women. So if you've heard of toxemia, or if you've heard of preeclampsia, these are the things that you go in to have your regular OB check, and you're kind of seeing spots and you've got a headache, you're going to be on your way to the hospital. They're not going to mess around with that, because that is a serious situation. I actually, with my problem, ended up with 180 over 130. That was my blood pressure. Since I have low blood pressure, or have had low blood pressure most of my life, that was really hard for my body to absorb. And I ended up in the emergency room because I ended up with a severe headache that I could not get rid of. So it does really affect some people. Resistant hypertension means that you have been tried on multiple drugs and your blood pressure is just not going down. My husband kind of has this variety, and it occurs in about 20 to 30% of people who have hypertension, and they do think it is genetically related. They haven't quite figured out why, but it can occur in people who have a history of obesity. African Americans are extremely prone to high blood pressure, especially men. And then if you have an underlying illness, like diabetes or kidney disease, you are prone to resistant hypertension. White coat hypertension is something that we create ourselves. When we go to the doctor, we freak out. We're like, oh my God, my blood pressure is going to be sky high, and sure enough it is. Or we just don't like to see providers. We don't like needles. We don't like whatever we're there for, a pap smear and a pelvic exam. So we freak out because we don't like being, at the mercy of a physician or a provider. Usually what they will do is they will say, gosh, this seems unusual. What are your blood pressures usually? And if you have a history of pretty normal blood pressures, especially if you're monitoring them at home, they will ask you probably for a log of those blood pressures and will ask you to submit that to them so that they can verify that this is white coat hypertension, or white coat syndrome, they'll call it. And it just means that you have an abnormal stress reaction to being in a provider's office or in a medical situation. Labile hypertension, I see a lot of people creating the wording label hypertension, but it's labile. It just means that the hypertension, it's there, it's not there. It comes and goes, it fluctuates. So, and you might even hear that word labile in terms of affect. When they're referring to a patient, they might feel like the patient is up one minute, down the next. So just think of labile as kind of a fluctuating wave. It changes over time. There's really no treatment necessary unless it stays consistently elevated. But that's what that would mean. So in the U.S., where I am, hypertension affects about 103 million Americans. The same statistic, or some statistics rate it then at 1 in 3 of us have some form of hypertension. And in Canada, the statistic is 1 in 4. So it's interesting to me that the medications to treat hypertension are listed on most sites as amongst the 3 top drugs prescribed. And that is true. There are a heck of a lot of things being thrown at hypertension these days. The current evidence is it used to be, you could get away with about 140/90, and now studies are showing that they want all these blood pressures at 130/80 maximum. So there is kind of a trend towards even more medication, and I will say that many of these medications are extremely, they make you very tired. They're drowsy inducing medications, so you do have to be careful about driving and things like that. Some of the abbreviations that you're going to run into, HTN, sometimes people will do HN for hypertension, but the most common should be HTN. An ACE inhibitor is going to be your angiotensin converting enzyme inhibitor. That's a mouthful. Your ARB. And usually when you're hearing these dictations, you're going to hear she's on an ACE, she's on an ARB, things like that. So this is where that comes from. And the more you read these things, these expansions, the more those letters will stick in your head. And of course, if you use a word expander, excellent. Angiotensin receptor blocker is an ARB. And your systolic blood pressure might be referred to as your SBP. And of course, we all know from our coursework, BP is an abbreviation they might dictate for blood pressure. Okay, now we're going to go into heart diseases, and I will tell you this is a quick crash course on a lot of them. Just to give you an overview, this by no means covers all of them. There are so many heart diseases out there. We could do another 3 webinars on those. But some of the main ones you're going to run across: congenital heart disease. That means your baby ended up with something that you did not plan on. You might hear the PFO, the patent foraminal valley. A VSD is a ventricular septal defect, or an ASD is an atrial septal defect. Pardon me. They might be caused by obstruction. Pardon me. they might be caused by cyanotic heart disease. These kinds of heart diseases are usually treated surgically. Sometimes they do it when the baby's very young, pardon me, and sometimes they do it when the baby's a little bit older. So these are some of the main ones that you will see. Then we have our arrhythmia disorders. Those are ones that they involve rhythm, obviously, with the word arrhythmia. It means that you can have a fast heart rate, you can have a slow heart rate, tachycardia, bradycardia. You can have premature ventricular contractions, or your PVCs, or abnormal beats, or PACs, premature atrial contractions. And here's a little graph of some of the rhythms, and then also our terms. We always want to know these, and you will run across these all the time in transcription. You can also have fibrillation, which is an irregularity, but you can have AFib or VFib. Some arrhythmias may become fatal. Usually ventricular fibrillation is not a good thing. They might treat an atrial arrhythmia with cardioversion, ablation. Actually, they might treat any fibrillation or arrhythmia with ablations or cardioversions. Some treat with medications, some treat subsequently with anticoagulation. Case in point, my mother had atrial fibrillation and she did not want to use anticoagulation. Excuse me. And she subsequently had a blood clot form on her brain, and she had a stroke because of it and died. So that is one of the unfortunate side effects of having a fibrillatory or arrhythmia heart condition, because you can throw blood clots and they can go anywhere in your body. One of the most common things we see, coronary artery disease. Arteries become damaged by infarct, or they can just become plugged up with cholesterol plaque, and that waxy buildup eventually closes off the artery. It can affect one, it can affect all of them. A friend of mine's husband had a quadruple bypass, so that means that he had 4 coronary arteries that were blocked, and he lived to tell the tale because he had a cabbage. And by the way, that is not spelled like the vegetable. Again, if you just familiarize yourself with some of these terms, like a PCI, that's a percutaneous coronary intervention, which I'll show you in a moment. A cabbage is a coronary artery bypass graft, and sometimes they will treat this with dual antiplatelet therapy and statins. So your dual antiplatelet therapy is something like Plavix or aspirin, 2 things together to keep those arteries open so that the platelets can't aggregate or form and close it off, and then statins to reduce that waxy buildup. But the other thing I would point out here, anytime you're doing reports and you have no idea what they're talking about, all you have to do is go to an anatomy site or Google what are the names of the coronary arteries, and that will help you tremendously. Another thing that you're going to run into all the time is dilated cardiomyopathy. It means that the heart muscle has become weak, and it always results in deterioration of the left ventricle. So as you can see, this thing is supposed to be this way, and it's gigantic now because it is dilated or expanded. You treat that medically with an ACE and ARB, digoxin, otherwise known as DIG, you will hear that, anticoagulation, and diuretics or water pills. They also treat that with pacemakers, ICDs, which is an implantable cardiac defibrillator, and LVADs, which is a left ventricular assist device that you actually wear. It's kind of like a vest. And they also do heart transplants if it becomes too bad. The one we hear about a lot, myocardial infarction, MI, a heart attack. It usually results in some part of the heart muscle dying off because it has had a blockage. It's like it's an insult to the muscle, and so it will hopefully recover, but it will probably always be damaged. As you can see here, this area would be damaged then because it was without oxygen and blood flow for a certain amount of time. There are lots and lots of different types of MIs. Anterior wall, inferoseptal. You'll hear all of these terms associated with that. And please do know that I do have this as a PDF, so all these links you can access. So if I always ask them to post it up with the webinar, but if they don't, feel free to email me and I will be happy to send you a copy of the PDF file. If you have a heart attack, it's going to usually be treated with a cardiac catheterization because they're going to have to go in there anyway, put a stent in, or they're going to do coronary artery bypass, or sometimes they will also treat it with meds if the person is too elderly, things like that. Heart failure is another super common thing. It can be left-sided or it can be right-sided, which means that the left side of the heart is affected, obviously, or the right side. It can be called congestive heart failure. It basically means that the blood is not pumping through the body appropriately. And what happens is you end up with all this extra fluid. They get fluid on their lungs, fluid on their legs. They have tremendous leg swelling. Even their abdomen can become filled with fluid, and because of that, now they're short of breath. They can't take in enough breath because of all this excess water or fluid that is circulating. So usually they have to treat that with an ACE, a diuretic, a low sodium diet, obviously, because sodium helps you retain fluid, and maybe something as simple as compression hose. But sometimes they have to treat it with a pacemaker or a defibrillator simply because it has gone on to the extent that it has now damaged the heart and they cannot get rid of all the fluid or whatever. It is something that happens quite a bit in older people, but it does happen even in younger people. So those are some of the symptoms. Hypertrophic cardiomyopathy, again, shows the enlargement of the heart muscle, but if you notice, in this case, it's mainly, the septum becomes so big. This is something that is the leading cause of sudden death in athletes. You hear that every once in a while, that he was perfectly healthy and he was running track and just collapsed and died. This is usually what it's from. And sometimes we have to really listen for this. I do a lot of cardiology transcriptions still, and it's very difficult sometimes for me to distinguish HCM or HOCM. They use that term HOCM, which I'll show you in a moment. But the HOCM is actually means that there's obstruction because of this hypertrophic cardiomyopathy. So if in doubt, I always flag it because I want to make sure they're very similar, but if it is obstructive, that should be, HCOM. They usually treat that with medications. They ablate the septum, as you can see here, which means they kind of burn that to reduce the size of it. They might remove part of the muscle, which is the septum. Here, the myectomy, they would remove part of that muscle. Or they might, again, do an implantable cardioverter defibrillator. I think I said that incorrectly before. Another common thing, mitral valve disease. That seems to be more prevalent than aortic valve disease or pulmonary valve disease, but you will hear those as well. But you hear this term mitral insufficiency. That means that the mitral valve is not working properly. You might hear mitral regurgitation, which means the flow is going back or regurgitating. or incompetence. It's just not getting through there properly. And it means that the mitral valve in all these cases is just not closing tightly the way it should. So it can cause a lot of different symptoms, especially in the elderly, but in any person of any age. Fatigue and shortness of breath. And as you can imagine, shortness of breath can present across a whole tableau of different cardiac diseases, because we've heard the symptom mentioned now several times. So they do usually have to investigate these by selective studies just to figure out, you know, exactly what kind of disease this person has. They usually treat this with diuretics, with anticoagulation, or surgery. The new thing is it can be a valve replacement. The standard used to be porcine, or they used to call them pig valves. They were from literally, you know, pork valves. Or nowadays they do this TAVR procedure, which I will show you in a little bit. They also can have mitral valve prolapse, which means that the valve doesn't close properly still, but it bulges upward or back into the atrium. And then you can have the flail valve, and you will often hear that. And the first time I heard that, I thought, what in the heck does that mean? But that is what it means. It's just kind of flapping. As you can see, the third picture, it's flapping in an abnormal manner, and that's a flail valve. If accompanied with mitral regurgitation, that means that the flow is going backwards, then it's probably going to require treatment. Another problem is pulmonary stenosis. This does happen in children and babies, and it causes what they called, in my day, the blue baby syndrome, where they're cyanotic. And it's because if you think of pulmonary and air and oxygen, they're just not getting enough oxygen in the blood. So the pulmonary valve is tight, making it harder for the heart to pump from the RV, which is the right ventricle, into the PA, which is the pulmonary artery, and it goes out to the lungs. So that's why they become blue. It can be treated with balloon valvuloplasty now, which means they just stick a balloon up there and dilate it, or they can go in and cut it, or they can actually replace that pulmonary valve, although that is a little bit less rare. 1 in every 4 deaths, so 25% in the U.S. is due to heart disease. 29% of all deaths in Canada are due to heart disease. So it is a very common thing. There's a lot of cardio transcription out there. These diseases can be treated with meds or surgery, usually. Arrhythmias may result in death. They are treated with meds usually, and procedures. Those are the things of choice. Common sense prevention. We should all quit smoking. We should all participate in regular exercise. We should have a heart-healthy diet. Avoid excess alcohol. Low sodium, low cholesterol diets would help keep a healthy weight. That definitely helps. And avoid drugs at all costs, because they do have extreme consequences on your heart. Treatment options. And we'll go through these a little bit quickly. Just I want you to have these for your own references. These are some of the most popular cardiac drugs. You're going to use your anticoagulants, your antiplatelet agents, and dual, that means 2 antiplatelet therapy drugs, ACE inhibitors, angiotensin receptor blockers, angiotensin receptor neprilysin inhibitors. These are kind of relatively new in my experience. Beta blockers, calcium channel blockers, cholesterol lowering meds, digitalis preparations, diuretics, and vasodilators. And those are not capitalized in ordinary terms, just so you know, but they were capitalized on that, so I did not fix that. And these also, I took these from a website. So they are, the brand name is in parentheses, but rivaroxaban, for example, is a generic drug and should be lowercase. All of these should be lowercase, just so you know. But your anticoagulants, they are going to stop they're not going to dissolve existing blood clots, like in my mom's case. There was already a blood clot. They cannot help. It's too late. They can treat certain blood vessel, heart, and lung conditions if they are given preemptively. They act as a precautionary measure, let's say, to getting blood clots. That's what they're for. So you'll always hear about Coumadin. Then you hear about Eliquis. That's one of the new miracle drugs, Xarelto, things like that. And then they use heparin a lot on people who are in the hospital. The dual antiplatelet therapy that I was referring to, they'll give you aspirin and Plavix usually, especially if you've had stents. They might give you ticagrelor, Brilinta. These are tremendous advances in medical therapy from, decades ago. They are used to prevent clotting in patients who have already had a heart attack, or they have unstable angina, they have ischemic strokes like TIAs, or they have other forms of cardiovascular disease, like they might have clotting or plaque formation in their lower extremities, let's say. They're usually prescribed preventively when the plaque buildup is evident, but there's not a major obstruction. But they also do give them after they have inserted stents. So, and they usually keep people on them for a year. Your ACE inhibitors, these take a constricted blood vessel and they make it into a relaxed blood vessel. And I think that's what happens and why it makes you tired. That's my humble opinion. But anyway, some of these common things, the names that we hear, benazepril a lot, captopril, enalapril, lisinopril, that's probably the oldest drug, I think, in that category. Quinapril, ramipril, they're used to treat or improve symptoms of cardiovascular conditions, including high blood pressure, but they're also used to treat heart failure. So, and some of these are kidney protective, such as lisinopril for one. That's a very popular one to protect your kidneys. The angiotensin II receptor blockers, those are your ARBs. And you hear a lot of those, Avapro, irbesartan, losartan, that's extremely popular here in the U.S. Valsartan, I think that's the one that was recalled though recently. Candesartan, these will treat or improve symptoms of cardiovascular conditions, including high blood pressure and heart failure. And one of the reasons for using it, if they weren't successful with an ACE, they might switch you to an ARB, or they might use it in combination. I do a lot of reports where people are on an ACE and an ARB. So it is, kind of a gamble sometimes. They try one thing. If it doesn't work, my husband's been through this many, many times, and they keep switching his medications. But eventually they do get the right ones that work and do not give you as many side effects. So again, one of the major side effects is going to be fatigue, which is metoprolol is especially bad for that. Now these are the newer ones that I have just started hearing about in the last couple of years, called the ARNIs. So if you hear a doctor say, he's on an ARNI, and you go, that's what happened to me. What? He's on who? They're used now for treatment of heart failure, and the most popular one at this moment is Entresto, or the only one that I actually know of, and it's sacubitril valsartan. It's a combination drug, and it's really weird dosing. It'll be something like, I want to say 49 and 51 milligrams, so it's a combination drug. But they kind of work together, and it's a relatively newer drug, but supposedly it reduces sodium retention, which is kind of good, and it decreases the strain on the heart, and they are finding that so far it's had really good results. So I hope that they don't find that it causes some horrible thing on the side, but so far so good. You will have your beta blockers. I'm sure you've seen this many times. This, of course, is generic. It can be hyphenated or not. You have your atenolol, your betaxolol, bisoprolol, and again here, this is a combination drug. So it's bisoprolol plus HCTZ, which of course is a dangerous abbreviation and always is expanded to hydrochlorothiazide, best known as Zyac, the brand name. Metoprolol, my worst enemy. I'm not a big fan of metoprolol. There are so many people on it, and with the great degree of fatigue that it causes, it makes me worry about people out there driving. Propranolol, you don't see that as much anymore. That used to be the one of choice. Sotalol is also used to help with arrhythmia sometimes. But these drugs are used to lower blood pressure. Again, they can be used for cardiac arrhythmias and treating chest pain, and they can also sometimes prevent future heart attacks in somebody who has already had a heart attack. Sometimes they use a combo of alpha and beta blockers. Carvedilol is the one that is most popular. And again, labetalol, you're going to hear that quite a bit. The only problem with these alpha and beta blockers together is they can cause dizziness if you stand up too quickly, because it causes a fluctuation in your blood pressure. Calcium channel blockers, those are used quite a bit here in the U.S. anyway. Diltiazem, amlodipine, nifedipine, those are extremely popular. They're used to treat high blood pressure, also chest pain, and some arrhythmias. Sometimes they put people on some medications just to stabilize the heart rate. Like if you have an arrhythmia, they don't want your heart rate to go up like to 150, so they'll give you something like metoprolol or labetalol, something like that, and carvedilol, something, and it makes the heart, you still have the fibrillation, but it slows the heart rate down, which is good. These are cholesterol lowering agents. Statins, rosuvastatin, very popular, atorvastatin. They have a lot of side effects though. They are used to lower the LDL, which is the bad cholesterol. Sometimes they give ezetimibe to go with that, or simvastatin, because, or this is a combo drug actually, Vytorin, because it will act as a helper to that cholesterol lowering medication. So it kind of promotes it. The digitalis preparations, in my day, they used digoxin and digitoxin. Now you usually just hear lanoxin. If you ever hear digeffect, that is slang in a lot of places. Will have you spell that out as digoxin effect, because obviously if you left it DIG, it's a dig effect. Most people get that by looking at that report, and in verbatim you would have to leave it DIG, but most places do have you go ahead and spell that out so that they understand. And sometimes they will refer to an EKG pattern in a report and say it has a dig effect, and this is what it's referring to. It shows this kick up here, the hockey stick configuration, which takes it from a normal ECG and turns it into that little hockey stick variation. So that's what they're talking about there. And they'll use those in rare cases. I don't think a lot of people use those these days. Diuretics are used. Those are water pills. They're trying to get that extra fluid off. And please ignore that this has a hyphen in it. I just noticed that. It is hydrochlorothiazide without the hyphen, otherwise known as HCTZ, which is a dangerous abbreviation. But mainly diuretics are used to, they do lower blood pressure because they lower the volume in the body. They lower other things too though, and that's why they have to monitor your BMP, or basic metabolic panel. They also take away that extra fluid. Vasodilators are your nitrates. They're going to give you nitroglycerin to stick under your tongue, a spray, a transdermal patch, an inch of nitroglycerin paste in the emergency room because you're having severe chest pain, and otherwise known as angina, and it opens up blood pressures, or blood vessels, sorry. Now let's go to testing. I will try to get through these quickly. One of the newest things I've run across is HFpEF and HFrEF. That's how they're pronounced. And the EF is going to be your ejection fraction, which is the amount of blood being pumped out of the left ventricle every time the heart contracts. But what is that HFpEF and your HFrEF? Well, it's heart failure, which is the HF, with preserved EF, which is the P, and it's a lowercase p, by the way, but I couldn't make it stay, preserved EF. So that means that the person has heart failure, but the ejection fraction is still normal. When somebody has HFrEF, they have heart failure, but the ejection fraction is reduced because of the strain on the heart. So I recently started hearing those and wondered, what in the name of heaven is that? And now I know, and it's very interesting, but again, it's sometimes hard to distinguish. Coronary catheterization, you're going to always have lots of coronary artery names, catheter names, femoral access, or radial access. They will go through your groin usually, but nowadays they often go through your radial artery and go into your heart to do that catheterization, or even stenting or ballooning. And I had that with my renal arteries. They went through a femoral vein to go to my renal arteries, which I did not know until it happened. So very interesting. Your coronary artery bypass, again, you'll hear things like LEMA, left internal mammary artery, SVG, saphenous vein graft. They take those from the legs and they put them up here to bypass an obstruction like right here so that there's clear flow. A REMA is a right internal mammary artery. OPCAP, you're going to have off-pump coronary artery bypass. These are just a smattering of some of the things that we hear every day. Your PCI, percutaneous coronary intervention. Sometimes you'll hear PTCA, and that is percutaneous transvenous coronary something. Oh, I forgot. Sorry. Went out of my head. Maybe it'll come back. Sorry. But they do deploy these stents, and once they're in there, they inflate them. They also might take a balloon in there and preemptively dilate that before they deploy a stent. Sometimes they have to leave a stent behind, sometimes they do not. In my case, they ballooned it and they did not leave a stent. But sometimes, especially in the heart, they will leave a stent to keep it open. You have your stress tests that will determine if somebody is suffering ischemia, or something is, you're not getting enough blood flow to a certain part of your heart. You're going to have a Lexus scan. They do with regadenoson, nuclear stress tests where they inject a tracer. You'll have just your basic treadmill stress tests. Most are all done though with Bruce protocol. You'll hear that it measures how long somebody went and measures the level of the cardiac workload that was generated. So you'll hear like, he did 9 minutes and 27 seconds for to 20 METs, and that measures their workload. It also will measure that ejection fraction. Sometimes you'll have to have, especially with arrhythmias, this is done right before cardioversion usually. Unbelievably, they stick a catheter into your stomach, and then they view images of the heart that way. So that is called a TEE, which is a transesophageal echocardiogram. Then they have a TTE, which is they don't stick a tube anywhere. They just go through these portals on the chest. So they're using sound waves to look at the heart, but it's through the thorax, not through the stomach, and that is a TTE. So it goes through the chest wall. And sometimes you just have to use logic, replay that over and over again. Was it a TEE or a TTE? And sometimes you can figure that out by the context as well. This is a standard cardiac ultrasound or echo. They just place the transducer on your chest, and then sound waves are used to image the heart. So, and they can do that, you know, in great detail, or they can do it in minor detail. I've seen both. But it does, again, give you precise measurements of the chambers of the heart. If it is in detail, it's you know, the best measure that they have of what each ventricle, which atrium is enlarged, things like that. But it also can pick up things like vegetations. Maybe somebody has, you know, an infection on their heart muscle, and it can pick that up, or it can pick up valves that are not opening and closing correctly. So that's kind of a cool test. Cardioversion, they put paddles basically on you, or pads, and they take this rhythm here and they shock you back into normal sinus rhythm. And you'll hear things like the pads were put on and they gave her two 200 joule shocks, and she converted to normal sinus rhythm. Sometimes it works for a little bit, and then sometimes it comes back. They can leave the hospital 2 months later, they can be back in atrial fibrillation. But some people have great success with it, especially if they're treated with the drugs like amiodarone, dofetilide, sotalol, and things like that. It can hold their rhythm. So sometimes they do for arrhythmias, pulmonary vein isolation, or a PVI. That also is used to correct an irregular heart rhythm. And what they do is they burn the pathway so that it can't do that anymore. It's like you change the path outside with, you know, you took a brush or a broom and you changed it so they couldn't go that way anymore. You'll also hear radiofrequency ablation, or RFA. A lot of times we hear STEMI versus non-STEMI, and that's referring to, or NSTEMI, that's referring to different kinds of heart attacks. And it all has to do with how the ST segments look on an EKG. And as you can tell, here's a normal ST segment. In a STEMI, that's going to be an ST segment elevation. That means the ST segment went way up, the second one. And it's the more typical, classic MI or heart attack. Then in the NSTEMI, you can have the ST depressions, and you'll hear that very often in your dictations. And you can also have T-wave inversions, and those are very common statements about heart attacks or EKGs. An NSTEMI is typically much less damaging to the heart than a STEMI. A TIMI, you'll hear TIMI grade flow a lot. And this refers to how fast flow is going through the coronary arteries. So when they start out in a catheterization, maybe that person had TIMI 1 flow. It's like sluggish. There's too much obstruction. It's like, oh, wow, this is going like mud. And then after they open it up, maybe they stented it, and now they have TIMI 3 grade flow, which is completely normal. And it's filling the coronary arteries as it should, and the risk of heart attack and stroke is obviously reduced. I mentioned before about the TAVR. This is the traditional. They used to go in, cut your chest open, of course, and replace a valve. You know, sometimes it fails. Sometimes they have to go back and redo it. That's obviously quite an extensive procedure. Nowadays, especially in the elderly, if they can, they want to go through a catheter. So it's a minimally invasive procedure, and they just go in. They have the guiding catheter, then they insert a balloon over it, then they insert this valve and they inflate it, and it's bing bang boom, and it's completely open and functioning. It's amazing, but it's called a TAVR, and it just means transcatheter aortic valve replacement, and it's extremely popular today. New York Heart Association symptoms, NYHA. These are always in Roman numerals, but they progress as somebody progresses in heart failure severity. So class 4 is very, very bad. They're probably going to need perhaps a heart transplant or an LVAD or something, because they can't do much of anything. But the symptoms just progress if somebody has heart failure, or it's not able to be treated adequately to cure it, from stage 1 to stage 4. So you will hear that quite a bit. You'll hear NYHA or New York Heart Association class 2. Atherosclerotic is the most popular that you should look for versus arteriosclerotic, although they kind of mean the same thing. They just mean that things are not elastic. And the thing, though, is in today's world, it's always going to be athero, because it means a buildup of plaque. A buildup that's preventing that artery from, just thump, 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 being able to process that blood. Ejection fraction, not injection fraction or injection fracture. If you just keep that in your head, an ejection fraction means what the heart is doing every single time. You would have, it's contracting. You would have dyslipidemia or you would have hyperlipidemia, but never both prefixes together. There's no such thing as hyperdyslipidemia. It's either going to be dys, which means bad lipids, or hyper, elevated lipids. Coronary artery bypass, as I said, a cabbage, not a cabbage that belongs in soup. Ectopy is a really weird word, but it means irregular or premature beats. See Chapter 14 in your book of style. Formatting is everything. That means your New York Heart Association is Roman. Different other types of classifications are going to be done in Arabic. Research is the only way to fly. That is the most important skill you can take from this course. Find glossaries of terms at these websites. If we do make a mistake because we typed in ejection fracture, we look like an idiot because we just didn't look that up. So I do believe that, we have a responsibility to do the best we can on every patient's report, and the only way that we can do that is to do research. Lori has a great webinar that kind of goes along with this about the heart. You can go on YouTube and look at all kinds of videos. Watch a TAVR. I do animated. I can't do real blood because I would fall off my chair. But you can look at all these procedures, and strangely enough, sometimes you can learn terms, medications, all kinds of things just by watching that. So if you're a visual learner, that's awesome. And reading sample reports, here are many, 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 many great resources for you. Okay, so before we get done, I just want to give you all a couple of quiz questions. So let's begin. The suffix in the word telemetry means what? And you don't have to type it in, just kind of mentally think of your answer. What does it mean? It means to measure. So if somebody is admitted to a cardiac service and they're going to have telemetry, it's going to be measuring their EKGs, seeing what their heart rhythm is doing. So that will help you remember that, I hope. Bradycardia is going to mean what kind of a slow heart rate, or what kind of a so sorry, what kind of a heart rate, a fast or a slow? I'm very good with secrets, obviously. HF that recovers is compensated or decompensated. And we didn't cover this, but heart failure that recovers. So what would you think just off the top of your head? Because you will hear something is compensated or decompensated. It is compensated because it recovered. So that means that it is not as bad as it was. So when you hear that somebody had compensated heart failure, that means it's improving. What is the root word in thrombolytic? Thrombo. It means blood clot. So when we have the word thrombolytic, if somebody has a stroke, they're going to throw a drug at it, probably a thrombolytic. And lysis means to break apart. So the blood clot is already there. They want to try and break it up. It's not a preventive measure. It's not a first line treatment. It's a desperate treatment to break that blood clot up. So that's why. Words for hypertensive urgency. And sometimes people think it's hypertensive emergency. It's really hypertensive urgency. Malignant hypertension. Remember our discussion about preeclampsia. The abbreviation for millimeters of mercury. If you hear somebody dictate millimeters of mercury, we would never ever put millimeters of mercury. We automatically, because it is a metric measure, we switch this to millimeters and the sign for mercury, which is capital H and G. A word for a valve with two cusps. That means it has two cusps instead of three. Bicuspid. So you would have a bicuspid mitral valve, let's say. What is the defect of sudden death in athletes? HOCM, or hypertrophic cardiomyopathy. The prefix in anticoagulation means against. And crescendo angina would mean it is stable or unstable angina. Unstable. Crescendo is kind of like that example of labile where it goes up and down, but with crescendo it means it just keeps getting worse. So that means it's unstable. Stable means it would be the same every single time. They would feel exactly the same pain. Systolic means what when we're talking about the heart? Contracting. Pardon my stomach. And a simple abbreviation meaning a heart attack is going to be MI, or myocardial infarction. Okay? And there are my contacts, and I'm so sorry. Let me just see if I, how can I tell if a medication is generic? You have to go, Valerie, to a viable website or use a drug book. I suggest drugs.com. It's simple, but you do have to click on the actual drug, because if you think about it, everything's capitalized. The first letter is capitalized because it's the first word on the line, or it's the only, or in the sentence, or it's the only word on the line. So you have to go deeper. You have to click into that medication, and it should say right under there, generic, and then you'll know that it's lowercase, so it's lisinopril. You can also do a quick Google search, and if it says the name of the medication, like lisinopril, it will show it in capitalization, but it says right below it, brand name, Prinavil, for example, so you know that it cannot be the brand name. It has to be a generic. That's a quick little trick. But always look those up, because those are always major errors, and employers get really mad about that. There's just simply no reason for us not to be able to distinguish that. Indy has that right, and that's a capital H and a lowercase g. Hg is the mercury part. Millimeters is the M. So if you just remember something's going to be 3 millimeters, they're both lowercase, and then your mercury is going to have that capital H, but they're joined together. And good point. rxlist.com, Courtney, that's a great site too. Oh, good. I think I even finished all of your questions. Yay! Well, that was a race to the finish. I always worry I don't have enough slides or provide enough information, and so I think I go heavy on the slides. Indy, yes, it will be posted up on the forum, and hopefully they will also post this PDF because it has all those great links in it. I really want you folks to have all those links. Read more reports, think about, cardiovascular things as much as you can, because there's a tremendous amount of work out there with cardiology and new things coming down the pike every day. So the majority of the work I do would be orthopedics and cardiology, sprinkle in some surgeries, and I always have enough work to give me all my hours and more. So if you know some of these certain specialties, you'll always shine. So make sure that you do, just use some of these resources. But if you do not find the PDF there, feel free to email me, and I'll be happy to send it, or just send it to instructors at canscribe.com, and they'll tag me and I'll send it to you. All right? But everybody have a perfectly wonderful rest of your week, and thank you again for coming, and I apologize for my little coughing jag there. All right. Nice seeing you all. All right. Have a great day, and thanks for listening. Bye.